Okay, okay,
Yeah, yes.
now, yes,
Okay.
yes.
Sorry. Okay. Thank you for Professor Dong So's introduction. I'm Dr. Lin from Taiwan. My topic is hybrid biflanged metal stent for different indications. I share our initial experience from Taiwan. So, sorry. Um, okay, US guy drainage procedure are increasing, so the biflanged metal stent plays an important role. And so biflanged metal stent can be divided to flare type and lumen opposing type. So so the flare type has limitations in terms of weak lumen opposing flows, so leading to the state migration because of the flare flange type. So now LAMs are uh, 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 may play an important role because the literature showed that the LAMs have the decreased recovery time and the cost compared to other treatments. So, but therefore, so far there are several main indications for LAMS placement. Most common use is for the drainage of the pancreatic fluid collection. Later, the LAMS got approved for the gallbladder drainage and for the CDS for the bile duct drainage if the ERCP procedures fail. And recently, LAMS also used for the US guide gastrojejunostomy for the gastro obstruction or SMA syndromes. However, the lens has some limitations in the case of the longer distance between the gastro wall and the target wall, because the lens stands the lens stands between the biflange is shorter than 1 centimeter. So nowadays the polymer stent is available in Taiwan, and it provides solid constructed biflanges and various stent lengths and various size. So we may call it a hybrid biflange metal stent. So as you can see, the diameter is from 10 millimeter to 60 millimeter, and the body length, the length between the two saddle is from 12 millimeter to 32 millimeter. So okay, so the delivery system is similar to the traditional metallic stent, and the the tip is olive shape, and it's not traumatic, it's soft. And there are 9 golden radio opaque markers, and there's a lasso, and it's very strong, and you can use it to reposition the lamps, and if you some problem in during the procedure. So nowadays we have some experience from Taiwan to use the pumper stent, and so today I share our initial experience. So the most common indication is to drainage of the pancreatic fluids, and one case is for Afferent Syndrome, and one case is for colorectal anatomy stricture. So there are 4 steps to have a successful deployment. The first one, the step 1 is to make sure the inner radial opaque is has passed through the gastric wall and the target wall, and then immobilize the inner shaft and firmly holding the shaft handle. This in the step 2, then we can slowly pull the outer sheets backwards to start release the stent from the delivery device, and we can watch to see the outer radial opaque. So until the first flange is open, and then we should stop deploying the stent, and we can move to the endoscopy view to see the black marker, and okay. So after the black marker is seen, and we can start to release the deploy the second flange, and to the gateway wall. So okay, now we can see the video. Okay, sorry. Okay, first after a radial opaque is passed through the gateway wall, and we can open the first flange, then pull back the stent. Okay, now release, pull back the scope. Then we can see the black marker in the endoscope view. Then fix the sheath. Okay, they started to deploy the second flange. Okay, after the deploy the second flange, then we can remove the sheath smoothly. So there's one advantage for the pumper stent is the lamps can be recaptured so during the deployment. So as you can see, it can be recaptured. Okay, now we share our first case. It's a 54-year-old woman, and she has a pancreatitis 2 months ago, and later he presented a wall of necrosis, and we used the pumper stent to have adequate drainage for these patients. So we use the cystotome and Visiglide to Gaiwa, and also use the T10 biliary dilatation balloon to have a tract dilatation. So firstly, we can see the, we can see the wall is here under the ultrasound, and we use the cystotome to have create a fistula. Then we recording the guide wire. Then we also use the outer sheath of the cystotome to make a dilatation for the fistula. Also, we also use the balloon dilatation to have the adequate dilatation of the tract. Then we inserted the pumper stent, and you can see the radial marker is here, and make sure the radial marker is passed through the gastric wall into the wall cavity. Then we can start to release the first flange. Then we pull back the sheath, and we can to watch the radial opaque marker. because the endoscope view is not so good, so we can we also can pay attention the radio mark is here, then we can is maybe is intra working channel, so we can start to have a second release of the proximal flange. Then we can it's finally it can be pull back the sheath and the guide wire together. 1 week later, we try to have to perform the endoscopy necrosectomy, and the necrosis tissue is easy to remove through the cystogastrostomie fistula. And 3 weeks later, as you can see, the fluid, the one cavity is almost shrunk. It's very amazing, and because there's one vessel is close to the lens, so we remove the plumbar stent immediately. Because the patient may have the disrupted pancreatic duct syndrome, so we put on the one double pigtail to keep the drainage. Another which also share our experience to how to use the plumbar stent. Actually, we have some accident in the during the LAMS the deployment. So this case is also a 54-year-old woman. She also have pancreatitis 2 months ago, and she develops a wolf necrosis. But during the lens deployment, the proximal flange was accidentally released into the cavity, or into the poor endoscopic view from the body collection. Okay, so next day we use the endoscopy to under the fluoroscopy to grasp the lens pull back into the stomach. Then we identify the lasso to use the forceps to catch the lasso and to have a reposition of the plumbar stent, and try to we can use the lasso to have the well construction of the proximal flange. Then it also it facilitates the reposition of the stent. So the use of the lasso is very important. Okay, so after the reposition, the necrotic fluid was drained very well through the stent. So 1 week later, we start to perform the necrosectomy. But before that, we remove the plumbar stent at first. And after removing the plumbar stent, we can easily to pass through the endoscope to the wound cavity to start the necrosectomy. Finally, we use the retrieval lasso by grasping the retrieval lasso with the forceps into the working channel of the endoscope. Then we reinsert the plumbal stent into the working channel. And then we replace the plumbal stent into this fistula, and to maintain the cystal gastrostomy, and we can perform multiple sessions of the necrostomy in the next week. So we also can use the lasso to reposition the plumbal stent. So we, because the patient have a large volume of the wound cavity, so we perform many times of the necrostomy with the hydrogen peroxide. And we also use the polycatch to facilitate the removal of the necrotic tissue. Okay. Another case is Afferent Syndrome. We use the plumbal stent to create anterior stomy. So this is also a 54 years old man. He underwent the Whipple procedure and with the Roux-en-Y reconstruction for the pancreatic cancer just 1 year ago. So he presented the dilated afferent loop and with cholangitis. So it's compatible the diagnosis of Afferent syndrome. Firstly, we try to use the enteroscopy to insert a metal stent. Unfortunately, it's failed. So we plan to use the US guide enterostomy to relieve the Afferent syndrome. So accessory including the Afferent needle, basically to guide wire, and also biliary balloon dilator and the cystotome. So firstly, we recognize the dilated afferent loop and use the 19 gauge needle to perform the contrast injection to make sure the jejunal loop. Then guide wire inserted into the jejunal tube. Then we use the cystotome and the balloon dilator to perform the tracheal dilatation. Finally, we inserted the plumbal stent, and as you can see, the black marker is here under endoscopy view. So we can start to deploy the second flange.
Professor Lin, we lost your voice. Hello? Professor Lin, can you hear me?
Okay, sorry, can you hear my voice? Okay, sorry. Okay, the case is provided by Dr. Lai. He works in Taiwan Hospital. The patient is a 29-year-old female, and she undergone colorectal surgery. But she has an anastomotic stricture 3 months after the procedure. So at first, he used the traditional metallic stent to try to create the stricture. Unfortunately, the stent is also migrated 2 months later, and the stricture remained. So finally, he used the pumper stent to provide the adequate dilatation for the anastomotic stricture, and he has a successful treatment for this post-surgery complication. So nowadays, there are some lumen-opposing metallic stent available in Taiwan. I think a pumper stent is has many advantages, especially we can choose different sizes. And the cost is also much lower compared to high shows. And the pumper stent also has an advantage for it can be recaptured during the procedure. So it's a unique feature. Another unique feature is the useful retrieval lasso. As I showed you before, we can use the lasso to have a reposition of the lens during the deployment. Or we can use the lasso to recapture the lens, to help recapture lens, and we can reuse the stent into the fistula. We can help us to perform multiple sessions of necrosectomy. So the near future, I believe heart pumper will be available on the market. So I believe the heart pumper will be more easily to be used during the procedure. So, in conclusion, US guided lens placement carries a risk of mail deployment, so the use of the retrieval lasso is very important during the reposition and the deployment. The pumper stent also called a hybrid biflanged metal stent because it provides many various size. So also we have experience to show you the it's effective to create anterior anastomy for the to relieve the Afferent Syndrome. So I also thank my team to help me to perform such a kind of procedures, and thanks to Professor Dong Wang and Professor Shobo Wang many teachings and training. Thank you very much.
Thank you, Professor Lin. You've made a lot of progress, and also we enjoyed your talk very much. If there is any question or comment, please feel free to start. Professor Lin, you mentioned about M.I.Tech new stent, plumber stent, and showed several cases of you've used for the drainage of pancreatic pseudocyst and the apparent lupus syndrome and the necrosectomy. Compared to, there are many different types of LEMS, lumen opposing metal stent. And compared to other LEMS system, what was the main advantage of plumber stent?
Yeah. Okay. In my limited experience, I think if the pseudocyst of the wall cavity, if the wall is thicker, more than 1 millimeter, it's not suitable for high shots or spacers. So we can choose longer plumber stent and to achieve the enough drainage.
Yes, I agree. Sometimes 1 cm or 2 cm lamps, the distance is very short. So we cannot reach the inside of the cyst or necrosis to gastric wall. So we are a little bit worried about sometimes migration because of the short length. And also there are several gold opaque markers, so it can be easily visible on the fluoroscopic image. And you also showed reusability of plumber stent. After removal for the necrosectomy, you can reload into the scope and reuse it. Do you think it is clean enough?
Clean?
I mean, after removal, there can be some contamination of the stent. So before insertion.
My assistant usually clean the plumber stent by irrigation of the normal setting, then reloading the plumber stent. However, we believe the necrotic tissue is more dirty, so.
But stomach is not completely clean organ, so yes.
Yeah.
Use it, yeah. Okay, if there is, I'm checking the chatting.
Professor
Yes.
Yes, Damien here. Can I ask a question?
Okay, yes, please.
Excellent talk, Professor Lin. Just want to clarify a few about the plumber stent, because for all these stents, I divide them into either true lumen opposing stents or stents that allow the stent to remain in place because of the flange. Do you happen to know the lumen opposing force of the plumber stent? Because if you start to do things like gallbladder drainage, GJ anastomosis, you want more lumen opposing ability because sometimes the stent may actually separate out. So do you happen to know what's the strength of it? I mean, has there been any benchtop studies done to show the strength of apposition?
Yeah. So you mean the anchoring force of the plumber stent is strong enough?
Yes, that's the question. Is it strong enough for like GJ anastomosis or gallbladder drainage? Because I mean, the previous studies on other stents have done benchtop testing to show which have better strength. So, because you mentioned that in your last statement that you want to start doing enterostomy, so you want the lumen apposition to be strong. Do you happen to have some data on that?
I heard that the anchoring force is not so strong as other lens, but in my experience, I showed the Afferent Syndrome case. Actually, he was admitted last week because he has a recurrent cholangitis. We see the plumber stent is lost. I don't know because the patient not follow up at my clinic, so we maybe the plumber stent may be lost just maybe 1 to 2 weeks ago, according to symptoms. And I think the next week I check the endoscopy view with the stent have been lost, and we also check the CT scan image show the Afferent syndrome is occupied by the tumor. So in my opinion, I think the tumor has strong the tumor progression is maybe the reason. Because in endoscopy view, you can see the anterior hysterotomy is bulging. I cannot find the orifice of the fistula, so I cannot do anything to even guide-wise is not difficult. It's not easy to pass through the original fistula. So just 2 days ago, I performed the HGS for this patient to relieve the jaundice. Yeah, so this is my limited experience. Only one is case. So for your question, for the pancreatic fluid drainage, I think it's not. Maybe the anchoring force is not so important because in my experience, I prefer to remove the lumbar stent for performing the necrosectomy because we can easily to go into the womb cavity to perform necrostomy. Then reloading the stent, so it's not a problem for the anchoring force. That's my opinion.
Yeah, thank you very much. Yeah,
thank you. Now it's time to move on to next talk.